Hello, I'm Sandra Jungers, and I'm excited to be here with you today to discuss developmental care and the impact that developmental care has in our neonatal intensive care unit. We're going to look at a few slides that talk about the past and about the present and a little bit about the future of what's happening in the neonatal intensive care unit. And then, and how all of this ties into developmental care, which is a big buzzword in the neonatal environment. When you finish this, one of three parts that we're going to be presenting that talk about developmental care, and of course this first one is a little bit more on foundations, but you will hopefully be able to, once you finish this class, to be able to assess and to discuss historical milestones and what impact that they have had in our neonatal unit. And you'll also be able to participate in discussions that are referencing developmental care and what impact it has had in our unit. I'd like to share with you today a quote that came from a very dear friend who actually is from Germany, and we're quoting a German philosopher today, and the quote goes, "All truth passes through three stages. First, it is ridiculed. Secondly, it's violently opposed. And third, it is accepted as being self-evident." And I guess the reason why I like this quote from Arthur Schopenhauer is because of the simple reason that it really depicts developmental care and the trials and tribulations that we've had with developmental care. If we all think back to 1984, 85, and 86, this is when we were first beginning conversations, and Dr. Heidelise Alls was bringing to the forefront the fact that we needed to be more keenly aware of what our environment was like and how this affected our infants in the NICU. But she was very much ridiculed because we have to understand that Dr. Alls was not an MD and that she was, in the field of science. And so, people just didn't think that the environment could possibly make a difference with our infants. And then, of course, as time passed, and we were beginning to see nurses and NICUs change their lighting, change their noise levels a little bit, or seeing how it would impact our infants, but also starting to nest and contain and to bring our infants more in a little bit of a midline physiologically flexed position, they were very significantly ridiculed by this. It was changing practice. It was interfering with what some people felt like was their ability to take care of the infant. But then, of course, time passes. And we have Dr. Jerry Merenstein in 1999 that actually spoke at the Developmental Intervention Conference in Chicago that talked to us about why we weren't doing this. And if you were not going to be practicing developmental care, then you should certainly do a study to prove why it was not advantageous to do this. So now it has become self-evident that developmental care is actually what we need to be doing in our NICUs. It's how we should approach our units every day. So I'm hoping that through the slides that we have in the next three presentations, you'll feel very comfortable in initiating discussions and implementing developmental care in your practice. I want to look at some historical data because I think it's always good that we get some foundations and we know where we're going. 1880, our preterm infants, the first preterm infants, were taken care of in a French hospital, and actually that's where we had the development of the first incubator. And then we moved just a few years down the road to 1893. We had the first actual hospital nursery where we had several babies in an area at one time. 1907, Boudin actually focused on the support of body temperature, feedings, and infection control. He's really the one that gave us some really good foundations for thermoregulation with our infants. And then, of course, moving on in historical data, moving on to that second stage that we might call it, is the fact that from 1960 to 1970, we actually got ventilators. And neonatology was being considered a specialty, and we actually had med students that were looking into going into this. And we had nurses that were actually wanting to work into the neonatal environment. We had the development of radiant warmers. We actually got the first central lines for infusions for IVs to help maintain our infants. And then, of course, we got transport teams, but those really came in the late 70s, and there were very few and far between. And then, of course, we really got into the fact that the environment with which we were treating our infants was probably not the friendliest environment that we could possibly have. We move on to the third stage, which we're looking at the 1980s and the 1990s, and we look at oxygen because that really became a priority of ours during this period of time. We had transcutaneous O2 monitoring. We had pulse oximeters, you know, the ones that drive us crazy now with all of the alarms. We have high-frequency ventilation being brought to us at this time. We've got surfactant replacements that are being introduced. And then, of course, we actually really have developmental care sort of making its debut, because in 1999, as I said, at the Developmental Intervention Conference in Chicago, we actually had some very true supportive efforts being made to make this an integral part of our practice in the NICU. We move on to the fourth stage of neonatal care, which is the 90s and the early 2000s, and we see family-centered care coming into play. We're seeing the fact that there are recommended standards now for NICU design, so that when we're planning a new hospital, when we're planning on redesign or reshaping our unit, we have some guidelines or foundations that will allow us to do it in the most appropriate way for our infants. Then, of course, the next thing that we find is the fact that brain growth and development of the preterm infant is a very hot topic, and that we need to know as much as we can about what is happening once that infant gets to our unit, and how can we protect and how can we embrace the growth and development that is taking place. And then, of course, follow-up care. We had never had early intervention clinics. We really didn't know what the outcomes of our neonatal patients were. So therefore, we did get our outreach clinics, and we were able to do follow-ups. So we now know that the environment really does play a very, very important part in what is happening with our infants. Looking at historical data, and you're looking at highlights and so forth. Also remember during this period of time that Dr. T. Berry Brazelton, all of us know who Dr. Brazelton is, and the fact that he brought us the behavioral assessment scale. And we also looked at Dr. Alls for that neonatal individualized assessment program that she brought to us, better known as NIDCAP. And then, of course, we had NAN to come to the forefront and say, we really need an educational program. We're certifying for critical care. We need to also take and look at how we can certify our nurses to know that they have the foundations and the history and the tools that they need in order to implement developmental care. We also know that there has been an expanded interest in brain growth and development. Some of this comes because of Dr. Stanley Graven from the University of Florida, and the fact that he does a program down in Clearwater, Florida, that is a wonderful addition to giving us the information that we need in creating better NICUs, in providing a more appropriate care, and looking at what some of our care practices actually do and impact the growth and development of our infants. We also see Dr. Bob White, who is actually one of the authors of the environmental design book that talks about what we actually really need in our NICUs to be able to create that appropriate environment. We are also taking and looking at the fact that we have national meetings on developmental care, and that they come around every year and they bring us the latest in information, and we are very comfortable in the fact that what we are doing is an evidence-based practice in our NICU. But we also really are focusing on family-centered care, and we have to tip our hats to Bev Johnson, who is sort of, I like to say, the mother of family-centered care, and the fact that she is really helping us to understand that it is very, very important, regardless of the age of the patient in the hospital, from the preterm infant, from our very small preemie to our elderly and patients, that family support is very necessary, and it's one that is very, very important to all of us. We have to then move on, and let's move down the road a little bit with some years. In 2005, we got those first private rooms in the NICU. You know, our adult critical cares had private rooms many years ago. And our patients on regular routine surgical floors, medical floors, had private rooms. And it took until 2005 for someone to be able to convince us that maybe a private room environment for our NICU patients would promote the fact of a more family-centered care, would actually help to promote the fact that we could have individualized control over light and sound in our units. So that's an exciting milestone that we have made in the care of our infants. And then, of course, in 2008, we did get that certification for NAN in the fact that we have a certification program. It is on the NAN website, and it is available for those that wish to try for certification in developmental care.